Welcome to The Explainer. So today we're jumping into one of the most intense and complex challenges in all of emergency medicine. What happens when a patient who has suffered a major trauma is also pregnant? It is a situation where every single second counts, and every decision affects not one life, but two.
Right? I mean, how do medical teams even begin to navigate this? How do you treat a patient when their own body has completely rewritten the rule book of human biology? So let's dive into the incredibly high-stakes world of treating trauma in pregnancy.
All right, first things first, let's get a handle on just how common this is. You might think it's a super rare event, but it's really not. We need to understand just how serious this scenario can be. And the causes aren't some kind of exotic, once-in-a-lifetime incident. The top three are motor vehicle collisions, interpersonal violence, and simple falls. I mean, these are things that can happen to literally anyone, at any time, which is exactly why being ready for this is so critical. Now, to really get why this is such a unique challenge, you first have to appreciate the absolutely incredible biological journey of pregnancy. The body isn't just, making space for a fetus. It's going through a complete and total redesign of its most basic systems. And this table here, wow, it really shows you what that reengineering looks like. Just look at the changes as you go from the non-pregnant state through the trimesters. You see the heart rate creeping up, cardiac output increasing, but the really big one? Take a look at blood volume. By the end of it all, a mother's blood volume swells by a staggering 45%. Now, on one hand, that's an amazing biological safety net. But in a trauma situation, it's also a double-edged sword. It means a mother can be bleeding and bleeding a lot before she shows any of the classic signs of shock, like a drop in blood pressure. It dangerously masks the problem. And get this, it's not just about blood. Her resting heart rate is higher. Her body's demand for oxygen shoots up by 30%. And all her internal organs in her abdomen, they get pushed up and out of the way by the growing uterus. So what does this all mean? It means the standard emergency playbook, well, you pretty much have to throw it out the window. So how do medical teams actually adapt? How do they rewrite that playbook on the fly when two lives are hanging in the balance and the patient's body is operating under a completely different set of rules? Okay, picture this. In the trauma bay, one of the first and most immediate threats is something called gravid uterus syndrome. After about 20 weeks, if the patient is lying flat on her back, the sheer weight of the uterus can clamp down on the vena cava. That's a huge vein returning blood to the heart. This can slash the heart's output by up to 30%, causing a sudden, terrifying drop in blood pressure for both mom and baby. And the solution? It's actually incredibly simple, but it is absolutely life-saving. All they have to do is tilt the patient 15 degrees to their left side, or even just manually push the uterus over to the left. That takes the pressure right off the blood vessel, and blood flow can be restored almost instantly. And to make sure they never forget these special priorities, teams use a modified checklist. You know the standard ABC for airway, breathing, circulation? Well, here it becomes ABCT plus UFO. That T is for the tilt we just talked about, and UFO stands for checking the uterus size and listening for fetal tones. It just bakes in the idea that from moment one, they're treating two patients. Okay, so let's zoom in on that second hidden patient, the fetus. Figuring out how the baby is doing is one of the most delicate and crucial parts of this whole process. The single biggest danger to the fetus after blunt trauma is something called a placental abruption. See, the wall of the uterus is stretchy and elastic, but the placenta isn't. So, in a sudden jolt, like in a car crash, the uterine wall can stretch while the placenta just tears away. This is catastrophic. It completely cuts off the baby's life support system, and it's responsible for a horrifying 60% of fetal losses in these trauma cases. So how do doctors listen for signs of distress like that? They hook up a continuous fetal heart monitor. And this graph right here shows us exactly what they're looking for. That top line is the baby's heart rate, and the line on the bottom shows the mother's uterine contractions. The story is in how those two lines interact with each other. Okay, so the key is all in the patterns. A healthy fetal heart rate is usually somewhere between 120 and 160 beats per minute. Now, if you see early decelerations, where the heart rate dips at the same time as a contraction and then bounces right back, that's usually okay. But the one that really gets everyone's attention is the late deceleration. See how the heart rate drops after the contraction has already peaked? That is a very, very bad sign. It's screaming that the fetus isn't getting enough oxygen. So with all of this going on, it leads to the most fundamental question, the principle that has to guide every single decision when you're trying to manage these two interconnected lives. What's the priority? And the answer, the core principle of everything, is unwavering. You do what is best for the mother first. Period. Every protocol, every single intervention is built on top of that one foundation. Why? Well, it's simple. You cannot have a healthy baby without a stable and healthy mother.
Think about it this way. Everything you do to save the mother's life, giving her oxygen, fluids, blood, you are also giving directly to the fetus. When you resuscitate the mother, you are in fact resuscitating the fetus at the same time. Their fates are completely, inextricably linked. So in the end, treating trauma in pregnancy is so much more than just a medical checklist. It is a profound test of quick thinking, a deep understanding of biology, and honestly, the incredible resilience of the human body. It really makes you wonder, in life's most critical moments, how do we balance medicine, biology, and hope when two lives are hanging in the balance?